Great. Well, thank you, Meredith, for getting us started. I really appreciate that. I'm Liz Hoy. I'm at NASA Goddard. I'm part of the NASA Above campaign and one of the co-chairs on this for this collaboration team. My other co-chairs are here as well, Jeremy Littell and Elizabeth Powers. And today we're going to be hearing from Dr. Tatiana Loboda. She's going to talk about fire, smoke, and human health and kind of the intersections of those with her talk. Dr. Loboda is a professor at the Department of Geographical Sciences at the University of Maryland, College Park. She received her degree there in 2008, and her research includes wildfire, biodiversity, climate change, public health, and their interactions with other human and physical factors on the landscape. And we're very thankful that she could come here today to talk with us. And I think what I'm hoping is that as we hear her talk, we'll think about the different ways that these two diverse aspects come together, kind of fire and human health in this region of the world. And then in our discussion, we can kind of think about ways that our collaboration team can kind of be at that intersection and maybe across agencies kind of move anything forward that might come out of this discussion. I don't know if Jeremy or Elizabeth, you had anything else you wanted to add?
Nope. Sounds good.
Nope. Thanks for the introduction, Liz.
All right. Thanks. Thank you, Tatiana. Take it away.
All right. Well, thank you, everybody, for being here. It's always exciting to have an opportunity to give a talk and then actually have time for discussion, which is a very rare occurrence these days. So I really appreciate everybody being here. I'm going to share my screen and start the talk. Please, I don't know, Liz, how does it go? Do you guys wait until the talk is over, or do you let people talk during?
I think it can be up to you, whatever you're comfortable with. We should have plenty of time afterwards, but if you want to let people ask a few questions in the middle, that's probably okay too.
I think it would be great if somebody has a question so that we don't have to kind of go back and forth in time, trying to find that whatever slide it was on. If you have a question, please feel free to interrupt, just unmute yourself and go ahead and ask the question. There aren't that many of us. So with that, without further ado, thank you again for being here. So I am working with an interdisciplinary team of fire ecologists, emission scientists, and environmental epidemiologists to look at the invisible cost of wildfire in the boreal and Arctic regions, and that's definitely the impact smoke on human health. This is a project that started about 3 years ago, and it's conducted jointly between the University of Maryland and the Michigan Technological University, where Nancy French is my co-I. And it is funded by NASA's Above campaign. So I like to put my acknowledgements up front so that we can get back to that at some point if needed. So I know that I'm preaching to the choir here when I'm saying that fire is really a very common and widespread phenomenon across the entirety of Arctic and boreal regions of North America. What you see here is our own MODIS-based algorithm that maps fire, and it actually captures burnt areas a lot better than the traditional algorithm, but that's a separate story. What you see here is that clearly, just based on the different colors, fires occur in this area every year, and fairly large fires occur in this area every year, right? Another thing that I wanted to draw your attention to is if you can make out individual fire scars at this scale, that means that those fire events are just absolutely huge, right? We're looking at a continental scale. If anybody can make out individual fire scars, that means that the size of those fires is hundreds of square kilometers. What you don't see here is where they're actually burning and the different composition of vegetation and fuels, as well as very deep peat deposits in some cases, which results in very substantial amount of emissions that these fires produce. So while looking at that whole Alaska, Canada, Arctic boreal zone, the amount of emissions is huge. And within the wildfire disturbance groups, we tend to focus on the amount of carbon consumption. In this case, we are looking at the amount of emissions and specifically looking at fine particulate matter at PM 2.5 range. And as you can see, the total amount emitted is very, very substantial. There is a big interannual variability with some years, 2015 being the worst on record. We've practically reached 4.5 million tons for the season. And in small years, it's about 500,000 tons. But on average, annually, we're looking at 1.8 million tons produced. That's a very substantial number. Because these fires are frequently very large, they're able to inject the plumes at the high levels of the troposphere, and therefore the smoke is transported over very large distances. In one of our previous talks and studies, we looked at just how far these fires can emit, emissions from these fires can reach in North America, and we established that pretty sizable amount of pollutants, PM 2.5 specifically, reaches southern states in the US, right? Reaches the southeast mostly. Interestingly, the Northwest is kind of protected, but that's a separate again story. We also know anecdotally that the emissions can go cross-continentally. We have Siberian smoke ending up in Alaska. We have US western fires, smoke reaching Canada and even nearing Europe, etc. So we know that we have a lot of fire, it produces a lot of emissions, and the emissions are being transported over very large distances. Separately from that knowledge, we also know that PM 2.5 are among some of the most harmful fire emissions to human health. And the reason for that is that the size of the particle is so fine that it can cross the blood barrier, right? And then it gets transported within the human body, impacting not just the respiratory system that you would expect, since this is air pollution, but as well as cardiovascular system, impacting the likelihood of stroke, of heart attacks, of arrhythmia, also impacting neurological system and brain, impacting pregnancy outcomes and birth outcomes, impacting pediatric growth and development, and clearly spiking medical emergency visits. So with that, the majority of the studies that you are seeing here are really based on a small sample of individual fire events, right? And then immediate impacts of those fire events are studied on the population in the nearby area. Because we are looking at the entire state of Alaska, the very, very coarse regional scale, and we're looking at the long time frame between 2001 and 2019, we had to develop a slightly different approach of how we're looking at it. So our approach combines our own burned area parameters, within which we calculate burn date using MODIS active fire detection, and then just modeling the likelihood, and the burn date gives us an approximate, a modeled assessment of daily area burns, right? And then using that information together with what fuels were there and what weather conditions were there, we're estimating emissions using the Wildfire emission inventory system, which is run at the Michigan State University. Oh, sorry, not Michigan State, Michigan Technological University. So there we have daily PM 2.5 emissions, and we have a certain grid upon which we operate, and each grid cell records a certain number of emissions in tons. Then we take each of those individual grid cells and we run a separate model in high split, where the emissions from that particular location are then transported across the North American continent. We have a specific bounding box within which we're looking. And then we take thousands of those individual grid cell emissions and put them together to create daily concentrations of PM 2.5 over the area. So this is a lot of processing that clearly takes a lot of computing power. We're running it on the high performance computing at the University of Maryland. It is an involved process, but when you have a good computing capabilities, it's definitely doable within weeks. And that's what we ultimately end up with. So we have our daily estimates of emission concentrations across North America as a whole between 2001 and 2019. And as you can see, the emissions are generally guided by two main principles, not just emissions, but the concentrations. Clearly where the fires are occurring and how intense those fires are, but as well as how the atmospheric transport impacting where those emissions are going and how they are pooling across this area. Also, what you're seeing here is how much of that plume ends up in continental US as well, outside of the Arctic boreal zone. Although the majority clearly stays within the Arctic boreal zone. Okay, so having those daily concentrations, we're then putting it together to look at the seasonal cumulative PM 2.5 across the 19 years in our fire record. And again, as you can see here, the patterns, the concentrations, the magnitude, it all changes from year to year. But there is literally not a single year within this 19-year record where we don't have a substantial amount of PM 2.5 from wildfires that is concentrated in the Arctic boreal zone. So the people who live there are chronically exposed season after season, right? And if they miraculously missed one season, they can pretty much guarantee to have some exposure to wildfire smoke in the adjacent years. And again, there are some areas that pop out as more problematic. Some areas experience events comparatively less frequently, and Alaska is definitely one of the known hotspots in the intermontane area specifically. How much PM is accumulated is still not really the basis of being concerned about health outcomes unless we can make that translation between the levels of PM concentrations and what is actually harmful to human health. That's where the air quality ranking comes in. And what we also wanted to see is how many days of air quality, poor air quality, which we here define as anything that starts with unhealthy for sensitive groups and goes all the way up to hazardous, this magic barrier of 35.5 micrograms per meter cube you have in North America. And when you look just at those poor air quality days, on average, there are certain areas within Arctic boreal zone that on average will have between 1 and 3 days of poor air quality every year, right? There are some areas that have as many as 10 poor air quality days on average, right? And if we're looking at maximum conditions, we have had areas that have experienced between 30 and 40 days of really poor air quality in certain bad seasons. And they're not necessarily contiguous, right? But they were a very large amount of time where people are exposed to elevated, seriously elevated levels of air quality. And if we look at any individual fire season, it clearly ranges. But 2004 was a particularly bad Alaska fire season. And you can see there was a lot of just unhealthy conditions, but unhealthy for sensitive groups, but there was a substantial concentration and just unhealthy for everybody, very unhealthy, and even some days that were very hazardous. It's the concentrations can reach very substantial levels there. So now that we know that there is a lot of fire, it emits a lot of PM pollution, that the pollution does reach where people live and in substantial concentrations, the next logical step is to try to figure out what the actual impact on human health is, right? And that's where stuff gets really challenging and confusing. And I'm really glad to see that we have people from the health side, because I have a lot of questions for you and a lot of pleas for appeals for pleas. Oh, sorry, goodness gracious. Appeals for help here. In the recent paper, and I believe Micah Hahn, I hope you are the author of that paper, the lead author, have done a fantastic job at looking at all kinds of health outcomes using the emergency department visits data between 2015 and 2019. Those are 5 seasons for 3 Alaskan boroughs, right? And if you look, and this is just one figure from that paper, they look at a suite of different conditions. And what really came out is a lot of honestly null results, with the exception of asthma. Asthma looks good. Everything else looks not statistically significant, with some small exceptions here. I don't know how many people here are very adept at interpreting the epidemiological models. What this one is saying, just very briefly, if the whiskers cross the red dotted line, then the results are not significant enough. And so the magnitude you can see here on the scale, this is really no change between, this is slightly below. So there's a protective, which is really weird. And this is definitely harmful conditions. So if you looked at asthma, you would say that children, it's mostly children we're talking asthma. People are much more likely to come to the emergency departments with an asthma attack during the smoke events. And here you have different lag days. 0 means the day of high pollution, and then 1 day, 2, 3, 4, 5 lags. So, and here asthma really is the only stable result that they were able to pull out. Everything else, in some cases, you can see that occasionally it pops out, but it's really hard to tell why ischemic heart conditions would be necessarily tightly linked with wildfire smoke. And the all respiratory, I believe that this is probably driven by the asthma, because nothing else, not bronchitis, not COPD, not pneumonia, came out as strongly correlated to wildfire smoke. And that's really surprising, because every single other study indicates that wildfire smoke pollution 2.5 p.m. really does impact all this suite of different conditions. So why aren't we seeing those results? Of course, as geophysical scientists, the first thing we want to do is, how did you estimate your exposure? And they used EPA monitoring stations as a point source to represent the entire boreal. Again, as geophysical scientists, we immediately say, well, you can't really use a single point to represent the conditions. We know from other studies that if you have 3 different point source measurements within a kilometer of each other, the differences that can be recorded at those stations can be very different. And it's true, right? So, but this is a really good first cut at the problem, and we're not seeing stable solutions. So in our study that we're working together with Alaska CDC group, we're looking at a much more detailed characterization of smoke pollution across Alaska. And what you see here is different individual zones by which we can estimate smoke pooling. Some of them are as big as a single grid cell, others are a little bit bigger, and they all depend on the distribution of the Indian Health Survey stations. And we're looking at the full scope between 2001 and 2019, and there are 645 individual IHS locations. So we have a big representative study. And over the last year that we have been working together with our colleagues, we are continuing to get null results as well. And that brings a series of big questions. The more we dig into these results, the more questions we have. And so why is it that with all the information that we have, we are not seeing the strong connection between degraded air quality and health in Alaska? And these are the things that I want to pose as questions and things to think about to you, and I'm really looking forward to hearing your feedback. We think that the primary reason that the results that we're getting are null is that the epidemiological methods that everybody is using to look at air quality connection to health are developed for densely populated areas, and they really do not work at all for rural mobile populations, right? And Alaska is a special case. When you look at fire impact in Los Angeles area, right? You know that there's lots of people in Los Angeles, and they generally stay there. They do not pick up and disappear for a substantial period of time. So those methods that are very robust methods that work great in cities and urban areas do not seem to be able to capture the situation in the rural mobile populations. For one, our numbers are small. Population of Alaska, for a huge state that it is, it's very small compared to population of Southern California, right? So the strength in numbers that we get from the statistics is just not there. Another big question that we really struggle with is we have no idea where people actually are, right? If they show up at a specific service station, a specific hospital, were they in that area? This is our current presumption, right? We're assuming that people go to the nearest point of service, and therefore they were exposed in that area which we're calculating emissions for, concentrations, sorry, for. But that's not at all a reasonable assumption for Alaska, because people do travel over very large distances, especially during the summer when they're doing a lot of outside activities. The identification of comorbidity in the data sets that the hospitals are collecting is fairly inconsistent. Sometimes it is collected, sometimes not, depending on what kind of symptoms the patient who is seeking care is presenting with, right? And frequently other conditions are not even considered, even if they're present. Another thing that we really don't understand about Alaska is how is the care accessed? You know, that brings me to the point where we were training for field work in Alaskan tundra in really remote areas. And the registered nurse who was doing the training ultimately looked at us and said, you know, everything that I'm teaching you is going to do you absolutely no good, because our current practices are designed to keep you alive for 15 minutes while the ambulance is getting to you. Anything beyond that, you're on your own. And we are very much in a similar situation here in Alaska. If people are in their remote camp, summer camp, are they going to be able to get to care if they're exposed to a lot of smoke? How easy is it, considering how sparse the road network is and how challenging it is to get the transportation from one point to another, for people to access care during those times, right? Is there any particular time during the year when it's easier than the others? We simply don't know them. Another thing we don't really understand is what the care-seeking behavior is. In urban areas, generally when people have a heart attack, they call the ambulance, right? Or they manage to get to the emergency department. We don't know how people are reacting to a difficulty breathing, for example, whether when they are adults versus when they're children, right? Why do we see so many children in the emergency departments? Is it because their parents are more worried when their children can breathe, right? Compared to when they can breathe or cannot breathe quite as well? Or there may be any other interesting limitations. We're not entirely sure what health outcomes we should be examining because of everything that I mentioned above. Technically, asthma is a good one, right? But only if people can get to care and their asthma is not very well controlled. It is quite possible that when people know they're going to be spending a lot of time elsewhere, they make sure that they're stocked up on medications and they have their asthma under control, no matter what essentially the small concentrations are. On the flip side, we know that small concentrations elevated cause heart attacks. But if those people cannot get to the health centers within 15 minutes, they're probably going to die, frankly, and we're never going to see that statistic in the health record. So that's a challenge. And another one is, how do we establish the proper assessment window for the case crossover cases? This is a typical epidemiological approach where each person is serving as their own test case and their own sorry, lost the word there. So essentially, every person is, goodness gracious. So every person, their reaction, their emergency hospital visit is tested against their own well-being before and after the smoke event, right? It is typical that in these cases, windows go somewhere between 1 and 5 and 10 days. This is the typical range. But we know from our analysis that in some cases, smoke pollution can persist for 40 days, right? So in that particular case, there is no difference. 5 days before, 5 days after, 5 days during. This is a really challenging situation that we generally don't come across in those individual fire event conditions when we know exactly what was happening on the ground during that time. And so with all that, I just want to kind of summarize where we are at this point. We know that if wildfires are really large and a persistent source of PM 2.5 pollution in the Arctic boreal zone, and we're doing a lot to understand the exposure better, right? On the geophysical side, there are multiple different efforts, multiple different modeling events, multiple groups that are trying to get a handle on the concentrations. Again, especially how sparsely Alaska is populated, how few monitoring stations we have. It is a challenge. So we're looking at converging lines of evidence to see how much different approaches vary from each other. But the biggest thing I would say, the biggest challenge that we have right now is that the existing epidemiological methods are just not suitable for the Arctic boreal zone. And that's why our current understanding of health impacts on wildfire-driven air quality is really rudimentary. The null results that we're getting may indeed be the true null results, or they very well may be inability of the methods to capture the impact. And we don't know, right? So it is the health data availability and understanding of population dynamics and care-seeking behavior that are right now, we think, is the weakest point here, not the better, faster, more fine-tuned smoke dispersion models. And so that's where I think I would like to stop and really open up for questions. Thank you.
Well, thank you, Tatiana. Everybody give her a round of applause. I have my clapper.
That's quite all.
We did have 2 questions in the chat that maybe we should just go back to first from Lynn Zender, who says, this was back where you showed that chart from the CDC that was very colorful. And was it 645 locations for care visits or 645 PM 2.5 stations or?
No stations. So there are no stations there, right? So it's the 645 locations with the Indian Health Survey includes.
Great, well, thank you. And now I would almost encourage, if you have questions you want to ask, you can type them in the chat, or feel free to unmute yourself, turn on your video if you want, and we can ask Tatiana our questions and then even enter into really a discussion too.
Maybe I can ask a question, Tatiana. Martin Stufer here from Alaska. Great presentation, wonderful overview. Thank you very much. I was wondering, in your assessment of the seasonal PM 2.5 amounts, what source for fire detection are you using?
Thank you. So our sources are based on satellite data. And so we have 2 things. We have perimeters, fire perimeters, and I have my colleague here, Tony Chan, who can refresh my memory. So Tony, we are using our Modis ABBA product for that.
Mhm.
Can you hear me?
Yes,
Yeah. So the fire data it's based on. It's actually not about Tatiana. It's Alaska Large Fire Database plus the Canadian
Canadian
National
Large
Fire
Fire
Database, the
Database.
boundaries. And then we used MODIS active fire data to track their the corresponding basically burn of day of year. So because for the emission estimation, we need to know when fire occurred. So for every single polygon that we have in the in the data pool, we basically located temporally the time of fire, and then we add that we add that property to the fire polygons, and then we ask the Michigan Tech people to run the simulation, and then on our side we took this emission simulation and run high split, which is a atmospheric transport model. So we can basically estimate the dispersion of PM2.5 from each individual fire sources. And we do this for every single fire source that we have, which has a lot of data sources to work with. And yeah, then that's how we came up with this. So if I
yeah,
hope
so
that
this
answers
is
your question.
what Tony is referring to. So we have within our burn parameters that we're getting from Large Alaska database and Canadian Fire database, we estimate burn date using MODIS active fire detections.
Mhm. Yeah, it's a it's a great method, and MODIS and VIAS are of course prime sources for fire detection. But and we all have great models. We have there's a big NASA hazardous air quality project going on where we also compare models. And of course, high split is a top model, no doubt about it. The biggest problem are the source data. And what we came up that often we have over 50% of our emissions from smoldering fires, which are just not detected by satellites, unfortunately, or barely detected. So I think your approach is very conservative, and it's probably on the lower end. And also when we look at the seasonal, I think the next slide you can see in 2004 we had 40 days with in interior Alaska air quality concentration approaching to 1,000 micrograms per cubic meter. So barely breathable air, and so that clearly shows that we underestimate the active fire burning and smoldering fires. But
No, you're absolutely right. Our estimates are very conservative because we're not considering smoldering fires at all. But even with that, we're still not seeing the connection, which is disturbing. It should be there, and it just isn't.
yeah. We came up for verification, also used the Purple Air network. Those are cheap sensors and not very accurate, but still better than nothing. Maybe something for the future.
The Purple Air, we are actually, a student of my PhD student is working on creating a different stream of assessment using the MODIS atmospheric optical depth in conjunction with fire, and we're using Purple Air and EPA stations to train your model. The challenge with that Purple Air stations are distributed only in populated areas. So very, very large areas in Alaska have absolutely no data, and we are not capturing the full range of emissions, especially where the emissions are super low. And that I'm a little concerned that's going to skew the models to some extent.
So Jeremy Littell puts in a comment kind of related to more monitoring, and he says that I thought that the ANTHC, which is I think the Alaska Native Tribal Health Consortium, where did it go? Was co-deploying relatively inexpensive air quality monitoring to airstrip met stations where they exist. He's not sure, but he could ask if that is happening or not. And then Lynn says she's heard the same. Oh, they are doing that, but are not deployed yet. Do you know when that's going to happen, Micah or
I
Lynn?
don't know. Mike just literally mentioned it to me maybe 2 or 3 weeks ago that they just got some funding to put them out. So I imagine it will be a longer work in progress, but that's my understanding too, that there will be some more purple layers out there that won't help with historical assessments and looking at retrospective data like Tatiana is trying to do, but it will help for sure moving forward.
Absolutely, and we are
Another-
actually advocating for this project. So that's great. We also plan to deploy purple layer on the Mesonet network over Alaska, so to have more distributed measurements. Thanks.
That would be great.
I also see Lori has her hand up.
Hi, I'm Lori Verbergy, and I just wanted to thank you for your presentation and say hello. I work here in Anchorage and as a toxicologist, an environmental toxicologist, and I've been working on trying to determine the health impacts of exposures to environmental chemicals for 25 years now here in Alaska. And I just want to welcome you to my world and tell you that you're spot on. There's nothing wrong. This makes perfect sense because this is what happens to us always. All those factors that you identified as your challenges, there are challenges and they're very real. And, you know, you're kind of, it's good that you got the signal pulse for, I mean, not good, but, you know, it's validating that you did see the signal pulse for asthma because, you know, it really is, with our small numbers and all the other challenges that you talked about, it's really hard to achieve statistical significance or to get, you know, the power that you need to do the statistical analyses and find these things. So you're spot on. And you know, well, I was curious, you're working with folks at CDC's Arctic Investigations? Is that who you're working with?
I gotta look at the email signature box. I see somebody who says Sarah logged in this call, and I'm Sarah.
Yeah, hi, this is Sarah Bressler. Yeah, I'm at the CDC Arctic Investigations Program in Anchorage.
Cool. Yeah. So maybe we'll touch base later sometime.
Yeah. So it sounds good.
Thanks so much.
Yeah. So I really, Lori, how do you deal with those things? Because this is unique to Alaska. I don't think there's another area in continental US that has quite the same situation.
Yeah, we also have another example of an area where we have challenges is when folks have concerns about whether contaminant exposures have caused cancer at elevated amounts in their community. And similarly, we have cancer registries and we work with our registries and mine the data and do our best to answer questions. But often, we don't feel that we can really answer those questions because we just don't have a big enough population to see, the statistical blip unless it's a really dramatic issue, which honestly, I don't think I've actually seen happen here in the time that I've done this work. So it's just a known challenge, and it's something that we explain to our communities, and we try to be honest about the uncertainty. And I always wonder if some amazing epidemiology method will come along, but I think numbers are numbers and stats are stats and our sizes are our sizes, and all of the things that you talked about in our healthcare system are also very real because the access to care is only at the hubs, and a lot of these exposures are happening out in the rural bush, and people need to come from the bush into the hub. And then sometimes if it's a really serious issue, they go to Anchorage, and that's where they are in the hospital. So you've got a real challenge finding out where people are from and where they were exposed. You've really hit the nail on the head with a lot of your things that you had on that slide about your challenges. And there isn't a good answer to make it better. I'm sorry.
Well, to me, that means we need to look at it as an opportunity. We need to convince NIH and probably NSF to fund studies that will allow us to get at those answers, right? And that means deep involvement with the communities. And they will never accept me as a, essentially foreigner, practically stepping into the communities and trying to do research. So it will really kind of be reliant on your connections with the communities.
Well,
and-
actually, we have Lynn Zender on the phone, and I would highly, toot her horn and let you know that she actually is a person who works a lot directly with the communities, a lot more than I do. And she would also be an excellent potential partner.
Thank you. And Lynn, I would very much like to connect.
Yes, that would be great. I was thinking the same thing.
See,
Thank you, Lori.
Micah has a question also, and there's a few in the chat we'll try to get to also. I want to make sure we have a few minutes at the end to try to think about if there's anything our team needs to take from this. But Micah, you want to go ahead first?
Sure. Yeah, I just wanted to say thank you for this great presentation. And it's, as someone who works on this stuff, it is super helpful, and it's exciting to see that other people are working on trying to do improved exposure assessments for wildfire PM2.5 in Alaska, because I feel your pain. We don't have the data, and we have to model it or reconstruct it some way. And it's a really challenging problem. So it's the more people that are working on it, I think the more we can hopefully converge on a solution that works. And so I'm curious, I think Martin's observations were really helpful in terms of thinking about where the exposure assessment might be off a little bit. And I wonder too with I'm not super familiar with high split, but my understanding is you basically, and based on the description, you were like running it fire by fire. And I wonder about, so does that mean if you're only using fire boundaries within Alaska, that means that you aren't getting any downwind smoke exposure either if there were fires that originated somewhere else? Is that the right understanding?
No, we actually ran this using all fires in North America. We're not looking at fires in Siberia.
Siberian. Yeah, got it.
So that's not part of it. But all the fires that burned in Canada were included in this. So, and we get a lot, we can see how much smoke is transported, both from Canada to Alaska and from Alaska to Canada. It's like, it's insane.
Yeah, no, I think another I'm curious to know of other validation steps that might be out there that you could take to sort of see where it is doing well and where it isn't doing well.
Yes.
I mean, I think it's just like, it's really tough. And so I think, just trying to break down the problem, there's stuff on the exposure side, and then on the health side, I think you for sure hit a bunch of the potential issues. Speaking about like Lori was saying, I was actually really not happy is not the right word, but for the assessment that you showed in Anchorage and Fairbanks and Matsu, I thought that the fact that we did find any significant result was actually indicative, I guess, or impressive given the small sample size that we have. Most of these studies are done in Denver or LA, as you mentioned, really huge communities. And so we were dealing with 26,000 cases over 5 years. It's a pretty small number of that's all ED visits, not for even particular health outcomes. So the fact that we found anything with a small number makes me say, this is a pretty significant health impact. So I think I wouldn't be discouraged, I guess, if you're finding lots of null results. I think you maybe hit on a lot of the reasons for that. But if you find even a small increase in risk, I think it speaks to the severity, I think, of the health impact. And the other thing I was going to say was that, there's lots of things you could tweak on the epi side. I don't know how you guys are setting up your models, but it looks like you're looking at maybe number of unhealthy air days people were exposed to. Is that right in terms of the potential exposure?
Micah, I'm not an epidemiologist.
Okay.
The extent of my knowledge is that we're doing the case crossover similar to what you used in your study.
Yeah.
And we're doing the same. We're trying different windows, and but we're not. So do we look at the number of consecutive day of exposure? I don't think so.
Okay.
So and that is the challenge always. But again, you don't know where people are.
Yeah.
See, what I came to the end, and it's always true. We can always fine tune our exposures, right?
Mhm.
The amounts,
Right.
the patterns, everything. But when it comes down, ultimately, the health side of it is so crude, and we're
Mhm.
just missing such vital information that even if we get the perfect exposures, I really don't think it's gonna change.
Totally. Yeah. And I mean, I'm not familiar with the IHS data look like. So I mean, CDC folks, Sarah, and whoever else you guys are working with, they know those data better. But I mean, for sure, whenever we're looking at health records in a medical system, like you said, that's indicative of health seeking behavior, not necessarily someone experiencing symptoms. So we always talk about this is the tip of the iceberg. We're only already catching a small number of the potential cases out there. And then on top of that, it's a small population to start with. So for sure, that's a major limitation. So, but it's great that there are even health data available, across Alaska that are consistent. So I think that you're on the right track. That's the data set. I think that's the only data set you could use. So yeah, there's just lots of, I guess, just to encourage, there's lots of ways to slice and dice the health side of things too, and also even, improving the inputs to the exposure assessment, then also like looking at PM concentrations or 2 days in a row or a number of, there's so many different ways to look at it.
Right.
So, which it becomes just like a statistical problem at some point. So
No,
yeah,
that's
keep
very
going.
good.
I really appreciate all this discussion, and we only have a few minutes left, and there's always, of course, more we can talk about too. But Jeremy, you've put a nice kind of idea for an action item in the chat here. I wondered if you wanted to just speak to that a little bit.
Sure. Tatiana mentioned, the barriers to working directly with communities, as scientists coming from what some call a Western science tradition. And there's, of course, a movement in many communities to have local observations and local participation in research that affects them, and all of the aspects of co-production that we find valuable. And if Tatiana's looking for potential connections there, I mean, we all have a lot to do, but one potential linkage, and Lynn's here, so she should definitely comment on this, because I don't know whether it's the right venue or not, but the Alaska Tribal Resilience Learning Network that grew out of Melinda Chase's involvement as the Alaska Tribal Climate Science Liaison, or whatever the position was called, funded by BIA, and she sat with us, and now is hosted at UAF on her own position. And there's a new liaison coming on, Justin Leon. Anyway, the Learning Network might be a place to go if some broader community effort is needed, because they often can provide that linkage and see what is known in terms of local observations or knowledge, and then connect those communities with researchers. But that's looking down the road quite a ways.
Thanks, Jeremy. I appreciate that. Is there, Jeremy, I think when we first talked about doing this webinar today, you had mentioned that this terrestrial team has in the past kind of tried to sync up with other teams to kind of move forward. Any thoughts on kind of the intersection between fire and health and air quality? Is there anything more we should be thinking about as a team to kind of move forward on this topic?
Well, originally those conversations were motivated by dialogues with EPA, and then those took a substantial hit in the intervening 4 years. And so they haven't really resurfaced in the same way as they were. I think now with Tatiana's work and others in IARPC, there's probably more potential to do something more, both more pragmatic and have more people involved. But what it looks like maybe should come more internally, because then it's more robust to the swings of political action. That said, if there's folks at EPA that others know of that want to be involved in this and have resources, or could work with us to try and obtain resources for those who need them, that'd be great. But I don't have any good ideas. I was more wanting to get a lay of the land of where it's at, and since then I've become more aware of Micah's work and seen what Tatiana's been up to, and so that's great. Those are awesome foundational pieces and places to start. But I think this is just to serve to reconnect the issue as something that we think of as important, and it's an obvious place for atmosphere, for Arctic observation, for others. And under the newer Arctic Research Plan, we might want to rethink about how we strategize.
Thanks. Well, I really appreciate all the discussion we've had. We've reached the 3 o'clock hour. There's 1 or 2 more questions we didn't really get to in the chat. So if people want to stick around, maybe if Tatiana has a few more minutes, she can answer them. But I think, we want to be respectful of people's time too. So thank you all for attending. And I appreciate that everyone could come and join today. And thank you, Tatiana, for.
I got to jump.
You've got to jump too. Okay. Well, if there's other questions, you go ahead and email Tatiana and we'll get them to her. Thank you all for attending.
Thank you.
Thanks, everyone.